So what we did was, for the first 6 weeks of the COVID pandemic, where we had collapse of services and we were very selective about who we could see in clinic, through the International Bowel Ultrasound Group, which is an amazing international collaboration of intestinal ultrasound experts, we identified a number of centers in the world that were doing exactly the same thing we were, carefully, thoughtfully selecting patients and appropriately applying non-invasive tools to keep them out of hospital. So our very good friends and colleagues in Adelaide, Australia, and ourselves, with some wisdom from my good friend, Dr. Chris Ma, we collated our data and recently submitted it for publication. So in the first weeks of the pandemic, we were able to see 84 patients in both centers, 51 patients in Calgary in total. And you can see a breakdown here. We had mostly Crohn's disease, but we also had ulcerative colitis in both centers. And we actually had 13 patients who presented with concerns for new or new presentation IBD. So about 30% of the patients who presented to the clinic were given a new diagnosis of IBD. Next slide, please. Of those patients, 95% of them avoided acute care endoscopy. So we kept all of these patients out of hospital, so they didn't have to go into the hospital where we provide our endoscopy services. And more than 75% of them had a change in management that was guided largely by those clinic-based evaluative measures that we applied. And we were able to thoughtfully expedite appropriate management in ill patients who had complications. So one young gentleman, for example, 21 years of age, university student, we brought right into hospital, avoiding acute endo, avoiding emergency, and scheduled him for an elective surgical resection of his small bowel because he had a stricture. Next slide, please. So I'll just give you a quick example of a case where we really found that the ultrasound helpful. And this again is a tool to objectively evaluate the bowel that is robustly been established as accurate when compared to either other cross-sectional imaging modalities or endoscopy. So Mr. TJ, it gave full consent for my presentation here. He's a lovely 60-year-old gentleman who'd been on methotrexate, one of the immunosuppressants previously, but had a little bit of liver enzyme abnormality and had been well for such a long time that he opted not to take the methotrexate and had actually been off medicine. In our clinic, we very carefully screen for flu-like symptoms or ILI symptoms, and he had no respiratory symptoms whatsoever, and all his stool studies were negative. He had quite classic pain that he'd had in the past with his flares, and so therefore we brought him into clinic for a face-to-face evaluation. Next slide, please. So I'm not sure if you can play the video, but I just want to highlight the white around the bowel is inflammation, and it's inflammatory fat. And you can see this black circular anatomic region in his belly. So we just very simply put a probe on his tummy and are able to depict the bowel in cross-section, see how it moves, see how it behaves. Next slide, please. And you can see from this picture in axial or transverse section, lots of inflammation around it, which is depicted by bright white type of picture. And then the blood flow within the bowel really depicts lots of classic Crohn's disease characteristics. So some docs would say, well, how do you know that it isn't something else like diverticular disease or diverticulitis or little outpouchings of the colon? Well, we can tell that on the images because we don't see diverticula. And certainly in rare cases, patients that are COVID positive can present with colitis. And so Gil Kaplan is working on a very important strategic research project to try to identify positive and negative patients by screening them further. We didn't have access because we weren't able to swab patients who came to our clinic. But this is certainly consistent with Crohn's disease, and this gentleman was started on effective therapy. Next slide, please. So how did this help him? We were able to use objective tools at the time of intervention. We then sent him for a fecal calprotectin to correlate with it. As you likely know, in many of these clinics, we don't have access to fecal calprotectin, often at the time of assessment. So we have to wait, and patients don't always love sending in their poop kits. So this gives us information very, very quickly, and we avoided hospitalization. Next slide, please. So really, what is the take-home message here? I think there's a couple of things. There are definitely system challenges that will provide obstacles to spreading intestinal ultrasound across Canada rapidly. We need to train docs. We need to remunerate them for providing the service. We need to shift our paradigm away from using tools like endoscopy or MRI that sometimes are difficult for patients to go through in order to share and spread this modality. But I put up this young woman's picture. Bree is her name, who has provided me consent a number of times as a reminder of why we do this. We do this because it's safe, it's tolerable, and it gives us incredibly important information. And I think this is the future. I have a side project where we're trying to look at artificial intelligence as a tool to aid in the diagnostic capability of ultrasound. And this technology is evolving so fast and in such an incredible way that one of the questions that was posed was, could one day patients have an ultrasound tool and know where their bowel is, and with some artificial intelligence, be able to show me by video when they're 3 hours away in their home in Medicine Hat what their bowel looks like? 5 years from now, who knows what we'll see? But I know the system has to change so that we can incorporate these very patient-centered tools into our evaluation. And I think what COVID has taught me, and certainly our team, is that this very safe tool should be leveraged in the future, because we don't need to necessarily scope everybody. And I think it helps us to be sure when patients are sick that we're doing the right thing.